Welcome to the Birth Journeys podcast. I'm your host, Kelly Hoff, BSN RN. I am a wife, a mother of two, and a nurse specializing in the care of women and newborns. In this podcast, we will share powerful journeys of birth givers with the goals of lifting the veil on the birth experience, healing through sharing, and beginning an open conversation to strengthen trust and promote transparency between birthing people and healthcare providers.
Hello. Today I have with me Anna Gates. Anna is 37 weeks pregnant and has a history of deep vein thrombosis. That means that she has had a blood clot in her veins. This makes her pregnancy high risk. If you want to understand more about deep vein thrombosis and the risks in pregnancy, listen to my bonus episode where Mike Goldstein talks about hematologic changes in pregnancy. Today, Anna and I are going to talk a bit about her upcoming delivery and postpartum experience, and answer some questions she has. Anna, welcome, and thank you for joining me.
Hello. Hi.
Hi. So do you want to tell us a little bit more? I kind of introduced your history a little bit, but do you want to tell us a little bit more about your history and this pregnancy and kind of some of what you've had to do based on your history?
Sure. So, hi, I'm Anna. And as you mentioned, I am 37 weeks pregnant. So this is my first pregnancy, and part of my experience has been dealing with the DVT aspect of pregnancy. So a little bit about my background is actually this started when I was 19. So when I was 19 and a sophomore in college, I tried birth control for the first time, and body did not like it. And I had basically a mini stroke when I was 19, and I was in the hospital for 3 days. Yeah, it was pretty wild. About half my body went numb. I couldn't speak. My tongue was heavy. Yeah, it was crazy. I was going to college at the time, which is how I know you. And
Time out. I don't remember any of this. This wasn't when I was your RA, was it?
No.
Okay.
I was living in my first apartment. This is sophomore year. So this was after freshman year of the dorms.
Yeah, that's right. Because I was your RA when you were a freshman. Okay.
So no, this was not going on in the dorms. You did not miss this. Yes. Yeah. Don't worry. So yeah, so I was living this is after freshman year, and I tried birth control for the first time. And it was an estrogen based birth control, and I had a very bad reaction. And they did a lot of work and testing. They found that I had no pre-existing clotting disorders, just extremely sensitive to estrogen based birth control. And they basically said, never again. You just can't be on it, and you have to be on progesterone only based birth control. So I was on Depo, Provera on and off for a long time. And that was basically my only option. So when I was 27, I talked to my doctor and I mentioned my history. And they said, since it was really vague and it was the pill form, that, they've come a long way. So roughly 9 years later, they're talking about different kinds of birth control and come along. And so they had NuvaRing now. And so I had a low dose of NuvaRing, tried that. 3 weeks later, I had a DVT that landed me in the hospital. My leg had swollen to twice its size. It was excruciating. It was very painful. I couldn't walk. And thankfully, the only reason I found it, or I knew that this was another blood clot, was because I had a follow-up appointment. I had gotten really sick. And you know how the doctor's office is like, oh, do you want to schedule a follow-up appointment in 2 weeks? And I was like, sure, And I was like, I'm not going to go for this, but, I might as well make the appointment in case I need it. And so at this point, the blood clot had been developing, and I thought I had pulled a muscle. I thought something, I didn't know. I didn't understand what was happening. I did this weird stretch and it felt really bad. So I thought I had injured myself. So my 2-week appointment followed up. And so I was like, well, I already have the appointment. I might as well go and ask about this, because this is like, my leg is really swelling here. And so I had a third-year resident that I was seeing that day at the clinic. And she's like, this could be a Baker's cyst, which is unusual, but it could also be a blood clot. Let me call the vascular lab. And she actually called with me in the room, and which I suspect that she was just really good at managing panic, because I don't know how often a doctor would actually do that now, but so she actually sat in there and called the vascular lab and said, hey, if somebody needs to get in, they're like, usually the appointment's like 3 months away. Let me see what I can do. We probably should get you in sooner just to rule it out. So I said, okay. And the lab, they said, actually, we had a cancellation tomorrow at 10 a.m. Can you do that? And I was like, I'm supposed to have company this weekend flying in. And my doctor was like, you should take the appointment. And I was like, okay. So I dragged myself to the hospital the next morning. He has the ultrasound on my groin, my left femoral vein, and he's 30 seconds. He's like, we're going to the ER. And that's how I found out I had a very severe TVT when I was 27. So basically at that point, it was 100%. You can never be on estrogen-based birth control forever. But one of the things that I learned is I got a lot of follow-up care. I started seeing a hemoc. They did a huge workup. And again, no clotting disorders whatsoever. It's just a sensitivity to estrogen. And it was enough to terrify me about birth control forever. But one of the things I learned is that, hey, when you get pregnant, ding, 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 guess who gets a lot more estrogen and guess who has a really high risk of clotting? You. So I was very grateful, even though 11 years later, I'm having my first baby. I learned at 27 and I had at least the mental preparation that I was going to need to be on blood thinners while I was pregnant. So fast forward 11 years, we had tried for 2 years to conceive. And so, being on Depo and other things like that, your body needs time to recover from long-acting, I think, birth control, at least in my opinion. But it took a while. And then, so finally, when I was about 6 weeks along, they went ahead and put me on Lovenox. And you take that once a day. And now when I hit 36 weeks, or actually a little over, almost 2 weeks ago, actually, but I'm almost 38 weeks, they switched me to heparin. And that's twice a day. And that's lots of fun too. So more injections. I'd like to say you kind of get used to it. Some sticks are better than others, but it's not fun, but it's necessary. So that's basically been my experience, and I just have it in the back of my mind of trying to get up and move around when I can, try not to be too sedentary, just the little things, making sure I'm drinking enough water. I think anyway, when you're pregnant, you need to be drinking a lot of water anyway, but it's just in the back of my mind, that fear of having a blood clot. And then of course, all the fears of, so if I go into labor and there's an emergency, I'm on blood thinners and it's a little scary to think of, what if there's an emergency? What does that look like? And, so just like an added layer of anxiety or fear about that condition. And I know we have ways to combat that and deal with that. And I know why you switch to heparin. It has shorter half-life and it's safer for going into labor, but it's still scary knowing that you have to have your blood thinned and to prevent that blood clot, but it's anxiety provoking. It's just one layer of it. So add on first-time mom plus the risk associated. Mm-hmm. Yeah. So that's me and my DVT.
I just interviewed another friend that's going to be airing in a couple days. She had a DVT with her second. From her calf to her groin. All the way up her leg. And she was on Lovenox and then they switched. Same thing. 36 weeks, switched to heparin. And she just delivered and she went into natural labor.
Oh, wow.
So, it happens.
Mm-hmm.
She's fine. Everything's fine. So if that decreases your anxiety a little bit, I'm sure they told you that for the most part, it's not crazy if you go.
Right. Yeah. And I feel like I have a really good relationship with my OBGYN, and I also have to deal with, I also have other specialists, maternal fetal medicine for my advanced maternal age.
Yeah, that's fun.
Yeah, right. I'm like, wow,
you just get more pictures. That's all that means.
Yeah, that's good.
You get more pictures of the baby.
I did
you
get
hang
a
out
lot
with your kid
of
a little bit more.
Yeah, I do have a lot. I have a lot of pictures, so it's really great. I feel like I'm very much paid attention to, so that's good. I've had a good experience with my doctors so far, but certainly there's been a lot of just, hey, don't worry, we deal with this. This is a common thing. This isn't that unusual. So that's nice to know too, that it's people know how to deal with it. It's not like, oh, we've never heard of this before. What do we do? It's not like that.
Going into this process, since you mentioned that this is your first baby, I asked you to have some questions ready. Let's just jump into those and then see where that leads us.
So one question I have that I haven't seen anywhere, if nobody's talked about, but I hope to be able to nurse and breastfeed. That's my goal. I know that doesn't always work out, but that's my goal. And I hope that happens. But when do you start pumping? I know you start nursing, you're supposed to start feeding every 2 to 3 hours. They always talk about that. And I'm like, When do you start pumping?
So it just kind of depends. You're going to have probably lactation consultants in the hospital.
Mm-hmm.
You will also, do you have a pediatrician yet?
Mm-hmm.
Do they have lactation consultants there?
I don't know. I should probably find out.
Find out. And then if not, then let me know and we can try to work towards finding a person in your area, because that's just something that I wish I had done for both pregnancies. Sometimes it's a matter of finding the right people for you. The short answer is there's no correct time. The longer answer is it really just depends on your situation. So if there's a need to pump in the hospital, they will absolutely 100% let you know. But it's good to have a lactation consultant on hand because there's indications for pumping and then there's when it's convenient for you. So if everything is going well, you could start pumping whenever it's convenient for you based on when you're planning on going back to work and all of those things. So establishing nursing over the first month is a great rule of thumb. There was a time where they were only recommending pacifiers after the first month. That's kind of become a gray area now. It's not as controversial to offer a different nipple in the first month. I think there's been some studies that have shown that there's really not a huge, what they used to call nipple confusion. So there's not as big of a risk for that as we thought. There's more evidence that it helps with the development of the muscles in the mouth to offer different nipples.
Oh, okay.
Non-nutritive sucking is good, and pacifiers decrease the risk of SIDS by up to 90%. So there's less focus on that whole no offering different nipples in the first month.
Okay.
That being said, if you really want to focus on establishing breastfeeding and getting that routine down in the first month, that's great. That will probably set you up for success. Personally, I started pumping after the first month just because you've got so much going on and I had no indication for pumping. My supply was good. My son didn't have any problems latching, that kind of thing. And so I just focused in that first month on finding a rhythm with him. So at the 1 month mark, if you're established and things are going well, what I have learned is that the milk supply is a little bit greater in the morning for whatever reason, hormonal stuff. I haven't looked into the scientific part of that. So what I would do is I would pump, again, very, very well established nursing. My child was not at all having problems with nutrition.
Mm-hmm.
I pumped in the morning first thing, and then I would immediately breastfeed after. I would get like a couple bottles, or not bottles. I would put them in bags and freeze it because I was trying to store up for when I go back and work 12-hour shifts. So if you're trying to like bank your milk and have a supply for later, and you're trying to focus on increasing your supply before you go back to work so that you can do all those things, because there's going to be supply changes when you go back to work because you're not physically holding your baby and having all of those hormones in response to you physically being around your baby. So you may want to consider like a first thing in the morning if your baby's well fed and sleeping and that kind of thing. So if you breastfed at like 4 o'clock in the morning and you want to pop up at like 6:30, pump and move on and breastfeed, that's an option.
Okay.
But if there's any problems with breastfeeding, that may not be the best option. After that, I would say talk to a lactation consultant, because if your baby's not gaining weight, if your baby's not latching well, if there's any if you have a supply issue, any problems whatsoever, may not be the best option for you. And at that point, I would definitely have a professional talk to you about that.
Are you pregnant and planning a hospital birth? You don't need a birth plan. You need a birth vision. In my opinion, birth plans set you up for failure. Yep, I said it. Hear me out before you turn off this podcast. You may think that by downloading a generic birth plan, it means you're in control. The truth is, it's not that simple. No one can control exactly how their birth will go. There are way too many variables. What every pregnant person wants is to walk into the hospital pregnant and to walk out with a healthy newborn in their arms. The journey in between is the murky part. It's hard to know what issues might come up that need to be addressed. If you focus your energy on a birth vision rather than giving your power to a birth plan, you can empower yourself to make the best choices for you and your baby. That's why you need to get into my Empowered Hospital Birth program. As a labor nurse and mindset coach, I can help guide you through the process of maintaining the calm autonomy that will help you achieve the birth vision you desire. In my Empowered Hospital Birth program,
I will help you identify the source of anxiety you have surrounding hospital birth, fill in knowledge gaps to make sure that you are fully informed and confident, learn key phrases so you can better communicate with your medical team, emotionally process your fears so that they don't hold power over you. Go to kellyhoff.com/empowered to book a free 30-minute private birth vision call, where we will identify your top fears and must-haves and gain clarity on exactly how you want to feel in the birth space. That's KELLYHOF.com/empowered. I'm honored to be a part of your birth journey.
I know that kind of looking at the services of the hospital, a lactation consultant comes in and speaks with you directly at the hospital. And then I know they have the services there, and then they have a 24-hour like support hotline too for moms that are breastfeeding.
Nice.
So like it's a service that they provide. It's not necessarily someone working with you, but if there's like hey, I have this little thing going on, it's the first line of, hey, call and someone can help you. So I know I do have that service available to me. So I'll have to check with the pediatrician's office to make sure.
That is very valuable, because being able to call at any time, that's amazing.
Yeah. What helps with milk production, or can you recommend anything that helps with, if you have a low supply? Is there any specific like supplements or nutrition or anything like that that's really good for milk production?
I will go ahead and start with what I did, and then I will tell you about some other things that I've seen friends do. The caveat is just make sure that your OB doesn't have any problems, or your pediatrician doesn't have any problems with you taking these things.
Okay.
A lot of them are in food. Fenugreek is what I tried first, and I feel like with my first, it was pretty successful. So in the 70s and 80s, they would tell women to drink beer.
Okay.
There is a good reason for that. There is something in beer called brewer's yeast, and you can buy that now. It's kind of bitter. It made me pretty gassy, full disclosure.
Okay.
But if you put it in chocolate chip cookies with oatmeal, it's spectacular.
Well, oatmeal chocolate chip cookies are my favorite. So you're speaking my language.
You add some of that brewer's yeast in it. It gives it this I don't know. It's it's not salty. It just balances things out to the point where I could not stop eating them.
Okay.
And then my husband loves them too. And he started eating them. He's like, am I going to grow boobs? I was like, probably not.
Yeah. You're probably fine.
Things that had to happen to me for me to grow boobs spontaneous.
You're right. Oh my God.
What happened to you?
Oh my God.
There's no human growing inside of you right now. There's also no human sucking on your nipples. So probably you're good, sir.
Yeah.
There's a tea called Mother's Milk Tea, and I can't remember all the things that it has in it. I would look at the ingredients, make sure you're not taking a supplement plus the Mother's Milk Tea.
Gotcha.
I hear from mothers that go back to work that their supply tends to decrease.
Yeah.
And that can happen for various reasons. Usually you're able to maintain your supply if you're with your baby 24/7,
right?
Because the hormone that is released when you're with your baby, your body can tell.
Mm-hmm.
And so they can tell that it's time to produce milk. And then if you nurse your baby, it's upregulated even more.
Mm-hmm.
But when you're pumping, those same hormones aren't released in the same quantity because your body can tell if your baby's not there. They do recommend that if you're pumping that you would have a picture of your baby or something.
Oh, okay.
Because the hormone will release a little bit more if you are looking at your baby. I would pull out a picture of my baby and suddenly have let down.
Oh, wow. Okay.
So very important to spend that time holding and cuddling and all that stuff with your baby. And then there's other reasons that your supply can dwindle. If you get sick, if your baby gets sick and doesn't want to nurse as much, when you start feeding solids, that it's normal for your supply to kind of go down a little bit because your baby's getting fed elsewhere. So if your body's stressed out, then there's the opposite hormone, the cortisol from stress can downregulate some of the good hormones for breastfeeding.
Yeah. And it's so hard. I think the hardest part about all of this is that it's what's going to happen. Are you going to breastfeed? Are you going to have to do formula because you can't produce milk? Did you buy the right kind of bottles, or is your baby going to hate it and they're going to like this one obscure bottle that you got as a free sample, that you can't find anywhere? It's just you want to have everything ready, but there's like no way to prepare. And it's infuriating for someone like me, but it's like, it's just like you're trying to prepare for all these possibilities just because I know pretty soon I'm going to be sleep deprived, you're going to be healing, and you're just like, you don't want to be figuring this out, but there's no way to know in advance.
If you have a good moms group in your area, and maybe search for some local moms groups on Facebook, because honestly, but if you find a good one, it's very helpful. The moms group that I'm in right now, they're my hive minds. I have a question about life or parenthood or where to take my kids for, a fun day out. Someone will give me the best answer, and many people will give me very similarly helpful answers.
Yeah, that's good. I think, the other thing too is, you want to do it the way that you're comfortable with, but you want the advice of more experienced people. But it's that fine line of like unsolicited advice or when people like got your way. Yeah. So I know what you mean. Like you got to find like a good group that like, let me answer the question you've asked and not volunteer and put my own agenda on you.
Right. Well, and the other thing is about motherhood is people have this, they have big emotion surrounding their experiences that you're talking to them about. And I've found a lot of people want to share that. And while that's understandable, it's not always helpful. So,
exactly.
For instance, if I were asking you about your birth story and jumped in and started telling you my birth story, but you're still processing yours and I'm still processing mine, it might not be helpful.
Right.
Because if you're just trying to share your story and process it and you've done it more recently, it can be a little bit overwhelming. And what happens with motherhood is a lot of times I feel like there's this feeling of isolation because there's no one way to do it and everybody does it differently. And then you're just kind of stuck in the home with these babies a lot more than you're used to. It's just a big change. And so you're having all these emotions and then other people are also having those emotions and everybody's trying to just like release those emotions and it isn't necessarily the most healthy or helpful.
Yeah. And that's what everybody's like, that's normal. I had this, that happened to me one time during my, and everybody has like something they want to share about it, which is great, but you're like, this could be completely irrelevant to my situation. And I think down the road when you processed it and you can hear it, I think it could be more helpful as like a discussion point rather than like, I can't take on more information right now.
Right. Please don't dump your emotional baggage on me while I'm just wondering which
right.
to buy.
Exactly.
You get better at weeding out information. You come into it with a purposeful mindset where if you ask the question and people are saying things that may not be the way you do it, you just kind of kindly smile and move on. And then you try to remember to not project your stuff. It's definitely a battle every single day. You had said there was 3 questions.
There's obviously so many things you're not supposed to eat when you're pregnant, but I know that changes. So when you're breastfeeding, are there any like major foods that you're like huge no, can't eat it?
So just be careful because, for instance, if you're to get food poisoning, you're not going to be very able to feed your baby. You might be dehydrated. You're probably going to be sitting on the toilet a lot. You're not going to feel well. So mostly just eat food that isn't going to make you sick.
Gotcha. Okay.
So like don't eat raw meat, right? Take care when you are ordering sushi. Weigh the pros and cons. I'm not going to tell you not to eat sushi.
Well, I don't.
I know people do.
Yeah, I'm not a sushi eater, so this will be easy for me to eliminate.
Oh, good. Well, then that won't be a problem. So, like the cheese, like the unprocessed cheese.
Yeah, unpasteurized cheese. Yeah.
Raw honey and,
Yeah. Okay. That's kind of what I would have generally expected, but enough. There's like, don't eat this while you're breastfeeding.
So there are people that will tell you that. There are people, including medical providers, that if there's any problem with your baby, if your baby's colicky or anything like that, they may say, oh, don't eat broccoli. Or cut out tomatoes. I would take that with a grain of salt because I'm not entirely sure how helpful it is to limit the diet of a woman that is trying to provide nutrition for her baby, kind of thing.
Noted. Okay. Don't obsess. Okay. Then that generally covers it. And then, my very last question, kind of a lot of it was related to like nursing and pumping and such, as we've talked about. But when does the risk of SIDS decrease?
6 months and then a year.
Okay.
The reason that I said that is because the American Academy of Pediatrics has gone back over the past couple of years and changed their recommendations and said that you want to have your baby in your room with you, not in your bed with you, but in your room with you for the first 6 months to decrease the risk of SIDS. They say things like have a fan on because that circulates the air and circulates the oxygen. Don't put anything in the bed with the baby other than the baby and what they're wearing. You can get swaddle clothing as opposed to a swaddle blanket and then lay them on their back. Oh, the pacifier. The pacifier, for whatever reason, decreases the risk of SIDS. And then at the 6-month mark, then they say that it's okay to try to move them into the other room.
Good to know. Yeah. The whole idea of like, oh, I worked so hard for this baby and then SIDS is like terrifying.
I was anxious for the first year with both of them. I mean, more anxious. I'm always anxious.
Yeah. I'm trying to stay in the mindset of, when you can ask yourself, okay, what could go wrong? All this could go wrong. And then I have to stop myself, but what could go right? So I'm trying to stay in that mindset, but it is still like, if you think about all the things that can go wrong, it's like, oh my God.
Yeah. It's also, when you meet your baby's going to have all these idiosyncrasies that you're going to have to troubleshoot as well. And so it's just a matter of trying to figure all of those things out with all the recommendations and still trying to stay sane.
Yeah. And I'm only staying home for the first 18 weeks. So my employer offers 10 weeks and then I've saved up another 8 weeks of benefit time. It doesn't feel like enough time, but I feel like it's more.
It isn't. 6 months is
I feel like more is so needed, but I feel like I get more than a lot of people do. It's just wild what we expect women to do who work and have children. Right. So
yeah. It's about. Do you have any questions about the labor process?
I think more so than anything, a lot of the advice I've heard is I've heard some people say, have your birth plan ready, but then also I've heard a lot of people say, yes, this is what you can hope for, but be flexible. So in terms of my birth plan, so much of it's going to depend on, I don't know if I'm going to be, if I'm going to go into labor naturally, or if I'm going to get induced. I know that one of the questions I had that you had previously answered was about the epidural. And I like the idea of, if you already have an epidural and there's an emergency, you're ready to go. And that was actually a really big relief. And that helped me make my decision just because that seemed to make way more sense to me that, in the crisis, that's like one last thing you have to worry about. So I know that's pretty much the plan. And then also love to have a natural childbirth. I mean, no, I think that's usually most people's goal, but just understanding that might not happen. And it's more about, what's the best for your health and your baby and like what you need to do at that point. So that's pretty much my birth plan. I'm just trying to be open-minded that it might not go the way I plan. And I don't want to get too fixated on it has to be this way. I don't want to lock in. And I also feel like that's a great way to make all of the nurses around you like hate you. If you're like, no, it must be this. They're like, okay, but so I
think people come in with this defensive mindset. And I think that as nurses, we get jaded by the birth plan because the birth plan seems like it's limiting our ability to save your life and the baby's life. And that's super frustrating. So if you're fixated on one thing, it kind of communicates to the medical community that you don't trust us. I have been saying that I would rather have people come in with birth preferences because the plan is something that we make with the patient and the medical providers. So we all sit down and we talk about the plan given the current situation. So if you come in laboring and you're laboring and there's nothing that we need to do, the plan is to let you labor. If we start noticing that your baby's heart rate is dropping, we may need to change the plan depending on the pattern of your baby's heart rate. So depending on how and when it's dropping and how long and a lot of different things, it starts to become very technical. And the evidence-based practice will suggest that we do certain things to make sure that you and your baby are okay. So perfect situation. You come in, you labor, you have your baby comes out screaming, everything's fine. We're not going to do anything. We're going to just let that happen. And that's what we want. We would really, really prefer that people come in and say, hey, I'm 6 centimeters. I'm just going to labor for a couple more hours without an epidural. And I'm just going to spit out this baby and we're going to push twice and everything, no tear. Like, we don't want any of those things to happen. We'd prefer to not race back to a C-section. These are all things that we don't want.
We're all on the same page. Yes,
and we know you don't want them to.
Yeah.
So and I get where the defensiveness on the part of mothers is coming from, because historically obstetrics has been very patriarchal. And the way that things were done before, moms would come in, they would get this, I don't even remember what they used. It was called twilight sleep. They would do like an epidural. They would cut an episiotomy. Baby would come out. And a lot of times mothers felt like they weren't involved in the process. And then they had these horrible episiotomies that didn't heal well because they weren't doing them right. And they weren't doing them for the right reasons. And there was all these complications because of all the interventions that were standard. These interventions are no longer standard. They are done only because of certain parameters that have been set in place based on evidence-based practice. And for the most part, if you have a provider that you trust and you're aligned with and they understand your goals and you understand their goals, the likelihood of these interventions happening unnecessarily is very, very low. Your provider is probably going to, at every step, tell you the recommended intervention, tell you why, and then ask you if you're open to that choice, unless they feel like you or your baby are in imminent danger and there's no time to make those decisions. So most of the time people come in with birth preferences that we all have. That most of the time we want to be able to do delayed cord blood clamping because that's evidence-based practice. But if your baby comes out floppy and blue and not breathing, we're not going to do that, because we're going to cut the cord and send the baby to the warmer so that the NICU team can help resuscitate your baby. And we don't want to do a C-section. Hospitals get dinged for high C-section rates. So there is a huge effort on the part of most hospitals to avoid, especially primary C-sections. So if a mother has never had a vaginal delivery, we don't want to do a C-section unless it's absolutely necessary, because we don't want you to have a scar on your uterus that would affect the next birth.
Oh, okay.
It increases the risk of you needing a C-section for your next birth. It increases the risk of uterine rupture in your next pregnancy. It increases the amount of time that you would have to wait to get pregnant again, because we want that scar to heal. Now, all of those things don't always happen in a perfect world. Like, people will get pregnant before that mark and they'll have the deliveries will be fine. But just statistically, when we look at evidence, that overall, it increases the risk. So we're not trying to increase people's risk. And in general, when you have a surgery, there are lots of risks. You have risks of bleeding, risks of infection, risks that it's not going to heal well, risks to the structures in your abdomen that are close to the uterus. So we're ramping up the risk every time we do a C-section. But if it's necessary, we are weighing the risks of the actual surgery versus the risks of what is happening in the labor process. And if they recommend a C-section, it's because take in those two things, suddenly the risks of what are happening in your labor process outweigh the risks of the C-section. And that's why they recommend it.
Okay. I like that. I like that birth preferences. I think that
would just change the energy of how you're approaching your medical team. And I think that it would go a long way to communicating that you are willing to work with them on the plan, that the plan is something that we come together to create based on what is happening and what is safest for you and your baby. And we're going to try to incorporate the things for you if possible, or we can tweak it a little bit, because everybody wants to make it a good process for you. So when the birth plan is so rigid, like for instance, if we're actively trying to save your life and your baby's life and you're demanding skin to skin, it's really hard. It's not impossible. It just makes our job harder because we have this goal of saving your baby or saving you. And it's just not, it's just very incongruous.
Yeah. I think that's exactly what I don't want. I have a very strong trust in the medical community, and I've had so far a very good experience, and I have a very good relationship with my OB, and I've actually met, all the ones that practice in the office. And like you said, you get to see your baby more often. You have a lot more appointments. Being an older mom, but that's the nice luxury. I've gotten to meet everyone. I know I'm going to meet a lot of new people in the labor and delivery process when I'm actually at the hospital, but I think just my general mindset is I have no reason not to trust you. I have no reason not to think that you're not going to do your best to help me, that you're not going to do your best to help deliver the baby. I feel like I know myself pretty well. And if I think I see something that's really concerning, sure. But at the same time, I think most people have the general disposition of, I want to help you. I went into this to help the process be better for women or delivery. So I think kind of going in with that mindset, I'm trying to be very positive. I have no reason to think that it's going to be problematic, but I think it's just, I like that concept of just like, these are my preferences, but I want to walk out of here alive and I want to walk out of here with a living baby. So you do what you got to do to make that happen.
And honestly, if people say that and they have their birth plan, then I feel a lot better. And I'm not saying that people don't have good reason for having their birth plan. I know people that have severe trauma and that have come in and said, this is my birth plan. And then it becomes very incongruous with keeping them or their baby safe. And I've had to sit down and say, I just want to start off by saying my birth plan for you is for you to be healthy and safe and for your baby to be healthy and safe and both of you to be alive. And so that's where I'm starting from. And then I will say, I would like to assume that that's where you're starting from, but I would like confirmation at this point. Is that where you're starting from? And then they're like, yes. Okay. So here are the things that we absolutely have to do to make that happen. And some of the things that are on the birth plan at this point need to be removed because they are not helping us progress towards that goal. But I would love to help you with these other things that we can make happen. The mindset changes most of the time when I say that. But it has taken me 7 years to be able to sit down and talk to someone that way because people do come in with a lot of baggage and trauma. And I've had patients that were combative that I've had to sit down and say that to them. Who knows how that's going to end, right?
Yeah.
But I don't want anybody to die. So
I think, a strong mutual goal. Don't die. That's just reassuring that, kind of going into it with this mindset, I'm trying to be flexible and not, again, just focus on all the things that can go right because I have no reason to think that anything's going to go wrong. So
do you have any procedures that you're nervous about? Like anything particular, like IV or just the process of the epidural or anything like that?
What's funny is when I was talking about my DVT when I was 19, I had to have a spinal tap. So I feel like I'm kind of familiar with, I know kind of what to expect, I guess, in that sense.
A spinal tap, like to see what's in your spinal fluid?
Yeah. So when I was 19, when they were trying to figure out what the heck was going on with me, half my body was numb. And so having a needle go in, I know it's not the same thing, but just like having that experience, I feel like I kind of know what to expect. I've heard all the horror stories of people's epidurals. And because, of course, as soon as you say it, they're like, oh my God, I had this nightmare situation, or I wasn't completely numb, or I could still feel it, or it wore off, or I can still feel it 2 years later. I can feel where it was at. Like everybody wants to tell you and share, again, their thoughts on it. So you're almost like, I don't want to say anything because like a number of people have had horrendous labor and delivery experiences. And some people have had, oh yeah, it was just fine. So like you have no idea where you're going to fall. So I'm trying to take that with a grain of salt. But I think like with the epidural, it's having that experience already, just trying to be familiar with that process. I think I kind of know what to expect. I don't know if it's like uncomfortable to lay there with it still in your back. I don't know. Like,
no, it's a flexible little tube that they're going to put in your back that about the diameter of like a fishing line.
Oh, okay.
So it's really, really small. And then they just tape it to your back. You're not going to really feel it. What you will feel is you'll feel cold whenever it goes into your back because it's just the temperature of the fluid coming in. I mean, we don't keep it cold. It's just not the temperature of your body.
Right.
Yeah. So you'll just feel the temperature change when it goes in. But it's so small. Some people freak out because they think that it's leaking.
Oh, I could see that. Yeah.
But it goes away. When they did the spinal tap, were you sitting or were you laying? Do you remember?
I was sitting, but I was almost kind of like leaning over.
It's
okay.
The same thing. But it's just, you're going to have a baby.
Yeah.
So it's going to be a little bit different. I'm not sure. It just, depending on like someone's flexibility, that kind of thing, it can either be fine or it can be uncomfortable.
Yeah.
But you are going to have to hold still and kind of just curl around your baby and have the worst posture ever. Tuck your chin to your chest, drop your shoulders, and have a nice curved spine because they're going to try to find that space in between your vertebrae so that they can get the needle in. And then they're going to feed that catheter into your epidural space. So they're not going to go in the same place as the spinal tap. It's not going to go through the same amount of tissue. They're feeding it into actually a smaller space. So the reason that people have it on one side or the other is because that catheter, like I said, it's flexible. It can feed in and kind of bathe those nerves on that side and not necessarily on that side. And what we do to try to alleviate that is if you have pain on a certain side, we turn you onto that side so that gravity can help the medication go into that side. If that doesn't work for whatever reason, sometimes if you have structures like anatomical structures, and again, we can't see that it's a tiny, tiny space, and it's really hard to, even if we went in with like ultrasound or imaging or anything like that, it'd be hard to see what anatomical structure is blocking the epidural. What anesthesia will do is they may come in and just kind of pull back on the epidural, just on the catheter, to try to straighten it out a little bit. If that doesn't work, if it's bad enough, they may recommend replacing the epidural. But there are things that you can do if you are still feeling it on one side. If it wears off, because everybody's body responds to the medication in the epidural cartridge. So it's a pump. It's a drip that you're getting until your baby comes out. But some people metabolize it faster than others. And some people metabolize different medications faster than other medications. So there are different medications that they can they can unhook it from the machine and give you a bolus of a different medication. And sometimes that helps. Yeah, there's a lot of things we do before we replace the epidural. Yeah, there's a lot of ways we can troubleshoot it. So I wouldn't be too concerned about the epidural. You will have soreness. Yeah. You can feel like a bruise. A lot of people say that they have back pain in general after the epidural, but really probably what's happening is you had a baby. So your whole spine and pelvis and your skeleton has shifted. Things have stretched out. So if you had back pain during your pregnancy, you might continue to have back pain afterwards. So you might need to see a chiropractor or a doctor or something, or a physical therapy or something, strengthening activity. A lot of people don't do the strengthening exercises that they need for their core to function correctly. So that's the reason that you might hear about that stuff.
I mean, obviously the other aspects or conditions, if you have to have an episiotomy or something like that. I mean, I'd love to walk away with not having stitches. That'd be great.
The episiotomy is not routinely done unless there's a provider that just specifically loves to do them, and that's their preferred method. I would ask your provider what their preference is, and the preference of many people in the practice. But I would bet that they say that they don't do them unless they're necessary. There are definitely indications for them, and they should tell you before they do it, or if it's an emergency, they should explain it afterwards.
Yeah.
For the most part, like if you have forceps delivery, if you have a vacuum delivery, if you have the baby that's malpositioned, if the baby's heart rate is going down. So if all these things have to be done in an emergent manner, it might be better to do an episiotomy to make space. And what they do is they deviate away from the anus, the whole point. The original episiotomy was supposed to be to avoid the trauma to the pelvic floor, but it ended up causing more trauma to the pelvic floor because then it would tear more. I mean, most people will tear. Most people will have a second degree tear. An episiotomy that doesn't tear more is in between a first degree and a second degree tear, but the goal is to keep it away from the other structures down there.
Gotcha. That's good to know.
Yeah.
That's really good to know.
And then ideally, if you have an epidural, they'll sew it up, but you won't feel it. And then it'll be a lot like a regular tear.
Yeah. Great.
It's easier if it's a uncomplicated episiotomy. It is easier to sew up.
Oh, sure.
Tear.
Yeah.
But if it's complicated by additional tears,
yeah,
then it gets messy.
Yeah. Yeah. I mean, I'm excited. I'm looking forward to having a baby and like feeling very positive about it. But I'm sure I'll have a lot to report back.
Can't wait.
So this happened. I didn't expect it, but we'll see. So
that's motherhood in a nutshell, though.
Yeah.
This happened and I didn't expect it. The end.
Well, good. I'm glad I'm on the right page here. Yeah, I think, that really answered the majority of my lingering questions. I know you've already answered several of them already. So,
well, if you have any more, just shoot me a message and I am happy to get answers for you.
Yeah, it's very much appreciated. And what you're doing is so important. So I appreciate it.
Oh, thanks. Well, I will talk to you soon. I'm excited to hear how everything turns out.
I'll keep you posted.
I'm sure it's going to go great.
Thank you so much for tuning into my podcast. If you enjoyed what you heard, make sure you hit that subscribe button so you don't miss out on future episodes. Don't forget to share the podcast with a friend who can benefit from the valuable insights that we share here. And if you could take a moment to leave a 5-star rating and review, it would mean the world to me. If you're ready to work one-on-one with me to embark on a transformational journey towards a confident and empowered hospital birth experience, Go to kellyhoff.com/empowered and enroll in my Empowered Hospital Birth Coaching Program. Together, we'll create a roadmap to a birth experience that you'll cherish forever. That's KELLYHOF.com/empowered. Let's make your birth experience extraordinary.